Hello, my name is Arpina Kudanyan, and I will be presenting about another great imitator, a case of a pulmonary mass in a 22-year-old patient. Objectives include recognizing the epidemiology and clinical manifestation for those with coccidioidomycosis, and to understand the limitations of serologic testing for coccidioidomycosis. Coccidioides immitis and Coccidioides posadaceae are fungi endemic in desert regions of southwestern United States and Central and South America, and they are the cause of coccidioidomycosis. About 10,000 to 20,000 cases are reported each year to the CDC. This map here represents average incidence of reported coccidioidomycosis, also known as valley fever, per 100,000 people by county during the years of 2011 to 2017. Let's talk about our case. A 22-year-old man presented with a non-productive cough, headache, and fevers. His exposure was notable for studying endangered rodents in Central California. On exam, he was febrile at 39.2 Celsius and tachycardic to 110. Other than his leukocytosis of 14,000 with neutrophilic predominance, laboratory studies were within normal limits. His chest x-ray, here in figure 2, found the left mid-lung field and left lower lobe opacification consistent with pneumonia. Empiric ceftriaxone and azithromycin for community-acquired pneumonia were administered. Cultures and infectious serologies, including typical and atypical pneumonia pathogens, coccidioides, typhus, and hantavirus, were sent and found to be negative. Mycoplasma pneumonia, IgG, and IgM were the only found to be positive. The patient was then discharged home on levofloxacin. Unfortunately, the patient kept having headaches, fevers, and developed this transient papular rash noted here in figure 1. Specifically, it was a diffuse erythematous papules concentrated on the left and right side of his back. His levofloxacin was changed to doxycycline empirically for typhus. Upon returning to the hospital, lumbar puncture was performed. His initial CSF studies were remarkable only for a traumatic tap, with no pleocytosis observed. CSF and serum were sent for a broad infectious workup. To our surprise, the CT of the chest found a subpleural mass, hilar central necrotic mass, numerous pulmonary nodules, and a bulky lymphadenopathy, all concerning for malignancy. Unfortunately, at this point, we were concerned, and therefore oncology was brought on board, who recommended biopsy of the lung mass. While awaiting pathology, serum and CSF studies returned. This time, beta-D glucan was positive. We obtained further details of the patient's exposure history, and he showed us photos of himself kneeling on the ground holding a giant kangaroo rat by the scruff with his bare hands. With this information, infectious disease started fluconazole empirically for pulmonary coccidioidomycosis. We were delighted to learn from oncology that the preliminary pathology of the lung mass was negative for malignancy. Later that day, tissue stains found evidence of Coccidioides spherules, here noted in figure 4 in a silver stain, showing the classic double-walled structures with morphological suggestive of Coccidioides species. And figure 5 showing multiple granulomas with spherules of Coccidioides as well. Serology from his second admission returned positive for Coccidioides, IgG, and IgM. So patients are symptomatic in only about 40% of cases and present about 1 to 3 weeks after exposure, and pretty nonspecific symptoms including fatigue, cough, dyspnea, headache, and night sweats, and sometimes even rash. Risk of complications is increased for those who are immunosuppressed. Serologic testings are vital diagnostic tools in clinical evaluation for coccidioidomycosis. Not uncommonly, patients will be worked up for malignancy while awaiting results for coccidioidomycosis testing. To further complicate matters, serologic testing for coccidioidomycosis are often insensitive in early infection. Although malignancy needed to be ruled out, this case offers reassurance that when a patient's risk factor points to an infection rather than cancer, we do not necessarily have to doubt our instincts. But even when patients have a glaring coccidioides exposure, such as our patient who routinely plodded around in the dirt of Central California, a confirmed diagnosis of coccidioidomycosis is not always made easy. Thank you very much for your time.